So our next speaker, welcome back to the stage, Joyce Black. Yay. Thanks. I would turn this off, but I don't know how.
Well, thanks. We're going to spend a few minutes talking about medical device-related pressure ulcers. The reason for the slide having fruit on it is I was told by a group that getting rid of medical device pressure ulcers was low-hanging fruit. How hard could this possibly be? So I'll let you decide at the end how hard this could possibly be. Medical device pressure ulcers are new in the area of pressure ulcers because I think what most hospitals have done is reduce the number of sacral and heel ulcers, and so in their pie chart, they're left with all of these other ulcers that come from various medical devices. We did some work at the University of Nebraska, published it in 2010, and we defined the phenomenon of medical device ulcers as ulcers that are due to pressure, but they take on the appearance of the medical device rather than the appearance of the bone underneath them. So what you're looking at is a paraplegic with a pretty good-sized ischial pressure ulcer, but he also has pressure ulcers from the Foley catheter, one on the scrotum, one on the inner thigh. And those of you that have been in the practice of healthcare for a while, probably like me, cannot remember the last time that they revised a Foley catheter. It's been the same. We still teach with the same ones we've used for 35 years. They're crispy, but we keep using them because they have not been redesigned. But what has been redesigned is our adult population. They're all bariatric. So where that catheter used to drape over the thigh, now it's stuck up in some fold someplace. So we did a literature review looking at the problem, and they've been described for quite some time. They have increased in their awareness, in their incidence, and they've increased in their severity. Part of the problem now, unlike deep tissue injury, is this time we do have heat and moisture accumulating between the skin and the medical device, further damaging the surfaces of the skin. Neck collars were one of the earliest ones reported as far as leading to occipital pressure ulcers and pressure ulcers along the face itself. And then oximetry probes have had a recent review because in our ICU patients, the finger probes don't work, and we end up with the ear probes, which lead to almost a burn-like presentation. The state of Minnesota did a large review of the problem of medical device pressure ulcers, and if you're interested in literature, that's probably one of the most comprehensive reviews. They found that the greater majority of their very serious pressure ulcers were from medical devices. Here's our study. We conducted it, as I said, in 2010. We looked at a little over 2,000 patients, trying to figure out what was driving our numbers. And you can see our literature shows you that we had about a 34.5% incidence house-wide of medical device pressure ulcers. And we found that people were more likely to develop regular pressure ulcers when they had medical device pressure ulcers, relating predominantly to the fact that these were critically ill patients. You'll see that we found all the stages of pressure ulcers beneath medical devices. We also found them in all the body parts. So even though you might think to yourself that, well, pressure ulcers of the buttocks, sacrum, etc., probably aren't medical devices, these were indeed medical devices. Foley catheters, as we just looked at, fecal containment systems, and so forth. I think we just looked at this one, didn't we? Oh, let me add on to this story. My little screen up here isn't working, so I'm trying to stare at that little screen down there. So pardon me for that. 63% of the cases in the Minnesota review had no documentation of any skin inspection beneath the device. There was no documentation that the device was ever moved or removed, hence the low-hanging fruit problem. Some of these devices cannot be moved or removed to look underneath them. And there was no pressure relief with dressings and things applied to it. So I'm going to go through a little bit of a portrait gallery here of patients with medical device ulcers to see if any of them look familiar to you at all. The oxygen delivery devices are the most frequent ones cited, and starting up at the upper right, that is a pressure ulcer across the bridge of a nose from a CPAP mask. To the left of that is tracheostomy tie pressure ulcer right over the carotids and jugular. The bottom left is a patient who ulcerated throughout his entire face simply from nasal cannula oxygen tubing. And the one on the bottom right is a lip ulcer from an endotracheal tube. The incidence is extremely high in this group of patients, from these ulcers reaching almost 100% in patients in CPAP and BiPAP. A couple of the issues you run into is there's such an urgency to maintain the airway and get the device on, particularly in the ER, that it may be difficult to figure out how you would do anything but maintain the airway. I'm going to encourage you to change your practice up just slightly and see if we can knock off those nasal pressure ulcers. And then there's also a great deal of difference in the face anatomy of various patients. Some patients have very thin faces, some patients have obese patients. This is a group from the ICU. That's pulse oximetry on the upper ear, almost looks like a burn. Coming down, that's an arterial line, a cock-up splint, and on the very bottom is an occipital ulcer from a hard neck collar. Very high numbers, and a lot of these cases, we have patients in the ICU, of course, with tons of medical devices. In case you don't have familiarity or you don't work in the ICU, heck, we've got them other places too. This is a bedpan pressure ulcer, an NG tube pressure ulcer. I don't know what that is. I called it bed trash when I saw it because I don't know if it's needle caps or what syringe ends or what that is. It actually could be a piece of the Foley catheter again. And then even stay suture, which are placed to prevent the suture from egressing into the abdominal wall, lead to ulcers themselves. I showed this photograph a few months ago in St. Louis, and one of the people in the audience said, that's just what you get when you have abdominal surgery. You should expect to have a midline abdominal incision and then this ring of pressure ulcers down each side. And so I told her, you're part of the problem, not part of the solution. You can't do that. TED stockings actually create something called TED sores rather than bed sores. We've seen the top picture before. That's the DTI on the bottom of the heel. The other one is a patient who didn't like the fit of the thigh of the TED stocking, so she rolled it down behind her knee and created a tourniquet-like response. So if you're still using TED stockings or elastic stockings, hopefully there's only one of you in the whole audience that is, I would encourage you to read the manufacturer's documents on it. It says do not use in people with vascular problems. So there's our issue. We certainly see device ulcers in bariatric patients. They tend to get lost in the skin folds, and they're often not manufactured long enough to clear any of the skin folds. So best practice, what can we do? I'd like to recommend that you figure out that these devices that you're placing on patients for monitoring, for therapeutics, whatever you're using, can in and of themselves lead to a pressure ulcer. Be sure that you're measuring the device and not guessing. I had surgery last November. I went to surgery in blue jeans because it was Omaha, Nebraska. And the nurse in pre-op simply handed me a pair of TED stockings. She didn't even know if I had legs. I could have been walking on 2 prosthetic limbs, and she didn't measure me at all and simply handed me a pair of TEDs. They fit. She was lucky. I have relatively thin legs. Be sure that you pad the high-risk area with the dressing, and this is where the ER could come into play. It is certainly possible to bundle either thin dressings with CPAP, BiPAP, or have them nearby or work with respiratory therapy to get them into place, and I think you'll drive down your numbers considerably. One of the issues that we see with trach collars is unwillingness of the surgeons to remove the sutures, and of course there's a great deal of fear about losing the airways. So a couple ideas on how to reduce them. Some hospitals are simply letting the staff nurses take out the suture of the flange at 5 days, assuming that the airway is relatively safe at that point. Other times, if we can get the pulmonologist or the surgeon to recognize the risk and pre-pad the area from the flange, it would be wonderful if we could get manufacturing to redesign the flange, because people's necks today are not like what they were before. Then when the straps go around the back of the neck, it's imperative that you look and feel behind those straps, padding the straps in the obese neck, and not waiting until you see blood on the bed linen to realize that there's something going on behind that trach. Oh, I just went through all that. Sorry, I got ahead of myself. Here's CPAP, BiPAP. We looked at the issues before. They do develop really quickly because of the thin tissue on the top of the bridge of the nose, and you don't have any fat on the top of your nose. So once you clear the skin, you're down onto cartilage or bone, and it can become stage 4, requiring reconstructive surgery fairly often. So these are the ones I think you need to work with respiratory therapy and see who puts the CPAP, BiPAP on, and whether they could put a thin piece of dressing just across the bridge of the nose and the cheeks, if that's an area you know that this patient's likely to ulcerate. I've worked with RT recently, and I was told by RT that they put the dressing on when they see a problem. That's too late. You can't see the problem. You got to address it before. Oral mucous membrane ulcers reasonably easily prevented, at least I think, by moving the ET tube from one side to the other. So I'd strongly encourage you to get an ET tube holder that allows the nurse to move the tube from one side of the mouth to the other. Ideally, each time the patient is moved in bed, but if not, at least once a shift. Oxygen tubing ulcers, probably the best thing I can suggest is that you look at silicone oxygen tubing. It has a reduced risk of ulceration. There are various devices you can buy. You can pad the whole face and ear and all of that stuff. But there's a part of me that thinks, I already paid for the oxygen tubing. Why should I now buy dressings on top of that? So if you're looking for a new product or you have problems with oxygen tubing, I would strongly encourage you to get the silicone-based oxygen tubing. Pulse oximetry is a problem. There's some data out on the intensity of the pressure from the medical clip pulse oximetry device. This I actually think is most easily solved by working with manufacturing and simply telling these people that their devices are leading to ulceration rather than going through all the steps that we want to, which of course is moving the device each time you turn the patient. The cervical collars are associated with occipital ulcers and ulcers along the face. A couple of ideas to reduce risk. One is to pad farther up the back of the head. There's an attachment that you can put on. You can see on the upper photo an attachment to the collar. You can also pad the occiput by padding the back of the collar with a dressing. A couple other things is to make sure that you look beneath the collar and take the front of the collar off. Use help to support the neck and hold it, of course, in a neutral position in order to change pads and inspect the skin. NG tube ulcers, there is a device around that is supposed to hold the ulcer in the narré, in the open narré. Important to use it rather than pulling it off onto the narré and pinning it to the gown, because once peristalsis starts, the NG tube will move a bit and will pull that tighter and tighter and tighter. I do think that there's a role for manufacturing in this whole thing, and I have been talking this story for a while. There are only a couple of manufacturers that have ever wanted to listen. Most of them tell me they've never heard of it. It must be the nurses in Omaha, Nebraska that do not know how to use medical devices. So if this is a problem in your facility, I would really encourage you to start keeping the data and writing, reporting, calling, refusing to buy, whatever you choose to do, devices that are associated with pressure ulcers, and put some demand on those companies to revise those products, because there's been no demand. I recently worked with a company that's revising the Foley catheter and making it longer so that that aspiration port and inflation port, which literally we use 2 seconds per patient, right? Inflate the balloon, deflate the balloon, is gone. So I don't actually know why we have it to begin with. If you have a hospital problem on medical device-related pressure ulcers, I'd encourage you to grab some of the posters that we did at the National Pressure Ulcer Advisory Panel. And if you can't remember that acronym, if you type pressure ulcers into your Google, you will find our website. We did ones on the ICU, we did ones in the general one, we did one for pediatrics, and we did one for long-term care. So I'd encourage you, this is a PDF, so what you see is what you'll actually pull off of our website. Well, I was also asked to speak about pressure ulcers on the heels, and pressure ulcers in the heels sadly can come from the boots that you use to prevent pressure ulcers on the heels. So they kind of go together, even though it may not be obvious that they do. The definition of pressure ulcers includes the idea that this is tissue subjected to pressure and made worse by the effects of shear. As we have patients in bed that are sliding down in bed, they catch their heels on the bed to stop themselves, and they get a fair amount of shear on the heel. In addition, if you're working with orthopedics, they may be, the physical therapists anyway, may be teaching the patient to put their heel into the bed and dig it down and then push it back and forth in order to set their quads. If you're seeing that, they're going to run into problems with blistering of the heel. And I would encourage you to work with the PTs to either put the patient in a stocking, not a TED, but a stocking that will block that, or put a hydrocolloid or a film dressing on the heel to prevent that blistering phenomenon. The NPUAP actually took the word friction out of the cause of pressure ulcers back in 2009. So if you do have patients that are rubbing their heels into the bed, agitated, confused, or even our orthopedic patients, they do not have to be classified as pressure ulcers. They are classified as friction injuries, and therefore, I don't know how much state reporting you do and root cause analysis you do, but you can take that one off your list. So catching the problem with heel ulcers where they start, heel pressure against the heel on a backboard is extremely high. unless you have a patient with a very large calf in which the heel is floated off the backboard. The backboard alone is a very, very hard, very firm surface. The operating rooms show about a 40% risk of ulceration on the heel in patients who ulcerate during their surgery. 40% of those cases are on the heel. And elevating the heel or floating the heel from an IV bag is not satisfactory. If you're looking at lots of issues with operating room pressure ulcers, the Association of Operating Room Nurses just came out with a position statement about reducing the risk of ulcers in the OR. So you may have some national leverage if you want to try to drive this one home. And then pressure ulcers under stockings and braces and splints and all of those things can also occur on the heel. I think the biggest driving factor for pressure ulcers on the heels, you can get really fancy and look at all this stuff, is immobility of the leg. And if you're standing at the foot of the patient's bed and you know that patient cannot lift their leg, or you ask the patient to lift their leg and they cannot, that heel's at risk. That really eliminates all the fancy stuff. If the leg doesn't move, the leg's at risk. So if this is a patient who's had a stroke, half their body's out, this patient who's quadriplegic, paraplegic, the heels don't move off the bed, and therefore the heels are at risk. We know the risk of ulcers on the heels is also higher in patients with neuropathic disease, including diabetic neuropathy. We know it's higher in patients with arterial inflow diseases. In fact, the time to ulcerate is very short in people with arterial disease. The reason I have end-stage renal disease on the slide is not particularly that renal disease in and of itself increases risk, but renal disease decreases the ability to heal these ulcers because we can't bump up their protein. So if you can just think about the fact many patients with end-stage renal disease are diabetic to begin with, but they're a very hard group to get to heal because we have so many nutritional impairments. And then, of course, those patients who are in the ICU do a lot of shunting of blood away from the legs, and therefore there's decreased flow to the legs. Whoops, jumped too far. Decreased flow anyway. Preventing heels in patients who have short-term immobility. So this is someone who lands in your ICU or will land in your ICU for what you think is only a matter of hours. You only need to float the heel. And the picture is actually my hand. I had a manicure done, so I wrote it off as a business expense. That's all it needs to be. It doesn't need to be up 6 inches off the bed. It really only needs to be up a distance of a ½ an inch. Some people have told me all you need to do is put a piece of paper under the heel and it's off the bed. That's not enough. So I want you to be thinking a ½ an inch. That's actually a rolled up bath towel. That's all that is to float that heel. It doesn't have to be fancy and it doesn't have to be boots, but it cannot be beds. There's no bed on the market that reduces pressure in the heel. So I don't care what they told you. I know you spent $75,000 on each bed, but it doesn't fix the heels. Some of the problems with conventional heel elevation, like this photo shows so well, this patient had her heels floated, but in her semi-conscious state, actually pulled that pillow up under her knees, and so her heels are back on the bed. So if you're using water-filled gloves, if you're using rolled towels under the Achilles tendon, if you're putting anything on the heel, you're not reducing pressure from the heel. All sorts of heel protectors on the market. I'm not sure what you guys use. I would encourage you to look at the side of the slide on the left rather than the right. At the top on the right, those are just an artificial sheepskin. They absolutely serve no purpose for heels or elbows. Take them home from your closets and let your kids, your children, your girls, anyway, use them as bra pads because that's about all they can actually do. The two on the bottom are orthotic type heel supports to give you 90 degrees flexion at the ankle. They're a great product, typically prescribed by physical therapists. They work well, except they injure the opposite leg when you turn the patient on their side. So you're better off with the soft boots that give you both 90 degrees foot flexion and heel elevation at the same time. So here's a couple of things I think when you're looking at a heel boot that you might want to consider. One is that does it float the heel? If the heel is still in contact with the surface of the boot, it isn't floating the heel. Oh, this gets fancy. I didn't know it was this fancy. Prevents foot drop. This happens to be one that has a strap that will prevent foot drop for you. Prevents internal and external rotation, therefore helping with perineal palsy. Controls heat and humidity. People tell us these boots are hot, so you like something that's relatively cool. And then remains in place when the patient kicks their legs about. So this happens to be a good boot on the market, certainly not the only boot on the market that will do that for you. Some clinical issues with boots, though, is people get ulcers from the boot itself. So the very device you use to prevent ulcers on the heel leads to strap ulcers on the top of the foot. So important that your nursing staff know how to take the boots off. I rounded in ICU 2 weeks ago. There was not one person who had their boots on correctly in the whole ICU. Took me most of my hour to round, redoing the boots. They need to be placed correctly. The nurses need to know how to place them correctly, because what you want to do is justify the cost. You want to be sure that when you're spending that much money, you're reducing that many pressure ulcers in these patients, and it's only going to work if you put them on right. The Canadians tell me that you can manage with one boot, and you can move the boot from the left foot to the right foot every 2 hours. So I told the Canadians they have more nurses than the Americans do, because we would never get that done. So I don't know if you can make that argument in your facility. It makes no sense to me. And then when you're using a hardback boot, be sure you're thinking about how hard that boot is, whether it's creating an issue itself. I'm not going to go through the clinical trials. There's a whole slug of clinical trials that lay out the benefit to a boot for you. Now, there is a group of patients who can't be in boots. They can't even have their heels elevated. The patient that has significant arterial inflow disease, or the patient in orthopedic hardware in which the leg can't be elevated from the bed, those patients, along with probably other groups of patients, particularly in ICU that have monitoring devices or therapeutic devices, we got to do something. So I would recommend that you at least think about whether you could use a foam dressing on the heel of those patients in lieu of nothing on their heel. This is a study done by Santa Maria in which he found that using the foam dressing on that slide, he knocked out his heel ulcers in the ICU in patients who were not placed in boots. So I think it's worthy of looking at. I actually think heel ulcers are the most easily prevented ulcer of all of the pressure ulcers, because all you need to do is float the heel off of the bed. And I think I have 90 seconds for questions.